If your doctor just celebrated the fact that your blood pressure is finally perfect at 120/80 and you are over the age of 75, what you are about to hear may completely change how you think about health, aging, and survival itself. Because according to growing evidence from geriatric medicine, the blood pressure target considered ideal for middle-aged adults may actually become dangerous in older patients. Not high blood pressure, low blood pressure. A major study published in JAMA Internal Medicine tracked more than 15,000 adults over age 75 for 5 years. These were not carefully selected textbook examples. They were real elderly patients living with diabetes, heart disease, previous strokes, kidney problems, frailty, and all the biological complexity that comes with aging, and the findings shocked many clinicians. Older adults whose systolic blood pressure remained below 120 experienced significantly more serious falls requiring hospitalization and higher overall mortality compared to patients whose pressure remained between roughly 130 and 140. In other words, the perfect blood pressure many doctors aggressively pursue may actually place some elderly patients into a more dangerous physiological state. That statement sounds almost heretical because medicine spent decades teaching one central principle: lower blood pressure saves lives, and for younger adults, that principle remains strongly supported by evidence. Lowering hypertension in middle age genuinely reduces risk of stroke, heart attack, kidney failure, and vascular disease, but aging changes the body profoundly. The same blood pressure number no longer means the same thing at 80 that it meant at 50, and this is where the conversation becomes critically important. Imagine a common clinical scenario: a 78-year-old patient enters a clinic with blood pressure around 145/86. The physician sees a number above current guideline targets and intensifies medication. One drug becomes 2, 2 becomes 3. Several months later, the reading falls beautifully to 122/76. Everyone feels reassured, the chart looks excellent, but then something else begins happening quietly outside the clinic walls at 2 o'clock in the morning. The patient stands up to use the bathroom. Within seconds, blood pressure collapses downward, the brain briefly loses adequate circulation, vision darkens, balance disappears, a hand reaches for support and misses. Suddenly, this is no longer a discussion about numbers. Now it becomes a hip fracture, emergency surgery, weeks of rehabilitation, loss of independence, sometimes even death. This sequence plays out thousands of times every day in aging populations around the world. And many specialists now believe it is not simply bad luck, it is physiology, because after age 75, 3 major biological changes dramatically alter how blood pressure behaves inside the body. The first is arterial stiffness. Healthy young arteries are elastic. They expand and recoil smoothly with each heartbeat, helping distribute blood efficiently throughout the body. But over decades, artery walls gradually stiffen through a process called arteriosclerosis. The vessels become rigid, less flexible, less capable of buffering pressure changes. This means older adults often require somewhat higher baseline pressure simply to maintain adequate blood flow to the brain and kidneys, especially while standing upright against gravity. The second change involves baroreceptors. These are microscopic pressure sensors embedded inside blood vessel walls. In younger adults, they react almost instantly when posture changes. Stand up suddenly, and the body immediately tightens blood vessels and raises heart rate to stabilize circulation. But aging slows that response dramatically, and if medication already pushes baseline blood pressure too low, the delayed compensation can trigger sudden pressure collapse the moment an older person stands. This condition has a name: orthostatic hypotension, and it may be one of the most underrecognized dangers in elderly medicine today. Orthostatic hypotension sounds technical, but the danger is painfully simple. It means blood pressure drops suddenly when a person moves from lying down or sitting to standing. For a young adult, the body usually corrects this within seconds. For an older adult, especially one taking blood pressure medication, that correction may arrive too slowly. The result can be dizziness, blurred vision, weakness, confusion, or collapse. And after age 75, a fall is not a minor accident. A single fall can fracture a hip, trigger surgery, lead to long hospitalization, reduce mobility permanently, and start a chain reaction that many elderly patients never fully recover from. This is why blood pressure treatment in older adults must be individualized, not blindly copied from middle-aged guidelines. The third major change involves drug metabolism at 75 or 85. The liver and kidneys no longer clear medications the same way they did decades earlier. A dose that appears reasonable on paper may remain active longer inside the body, accumulate more strongly, and push blood pressure lower than intended. This means a patient can look perfect during a seated clinic reading while experiencing dangerous pressure drops throughout normal daily life, and that is exactly what makes this issue so deceptive. The number on the cuff may look beautiful, but the person feels weak, foggy, unstable, and afraid to stand. A large real-world study of more than 15,000 adults over 75 divided patients by systolic blood pressure ranges below 120, 120 to 130, 130 to 140, 140 to 150, and above 150. The lowest mortality was not seen in the group below 120. It was seen among patients around 130 to 140. Those below 120 experienced more serious falls, higher acute kidney injury, and increased overall mortality. Meanwhile, patients above 150 did show greater cardiovascular and stroke risk, proving that very high pressure remains dangerous. But the uncomfortable message is clear: too low can also kill. This completely changes how elderly blood pressure should be discussed. The goal should not be chasing a textbook number at all costs. The goal should be preserving circulation, preventing stroke, protecting kidney function, and keeping the person safely standing, walking, thinking, and living independently. For many adults between 65 and 74 who are healthy and physically active, a systolic target around 130 to 140 may offer strong protection without creating unnecessary danger for adults between 75 and 84, especially those with age-related vascular stiffness. A range closer to 135 to 145 may be more realistic and safer for adults over 85 or those who are physically frail. Even 140 to 150 may be clinically appropriate depending on individual health conditions, and the bottom number matters too in older adults. Diastolic pressure should often not fall too low. When diastolic pressure drops below about 65, blood flow to the heart muscle itself can become compromised during the heart's relaxation phase. That means even if the top number looks acceptable, the lower number may reveal danger. This is why older patients must stop asking only, "Is my blood pressure normal?" They must begin asking, "Is this blood pressure safe for my age, my medications, my symptoms, and my body?" Because those are very different questions, and the answer may determine whether treatment protects the patient or quietly places them in danger. One of the biggest failures in modern blood pressure treatment is that medicine often treats numbers instead of people. Two elderly patients can walk into the same clinic with identical blood pressure readings and require completely different medical decisions. Imagine two 81-year-old adults, both with readings around 158 over 88 on paper. They appear identical, but the first patient has chronic kidney disease, mild heart failure, osteoarthritis, and struggles with balance. The second remains physically active, walks daily, golfs twice a week, and functions independently without major illness. The blood pressure number is the same. The physiology is not for the frail patient. Aggressively forcing pressure down may become dangerous. Excess medication may worsen kidney function, increase dizziness, and dramatically raise fall risk. In this case, preserving stability and circulation may matter more than achieving textbook perfection for the healthier patient. Moderate lifestyle adjustments alone may safely reduce pressure into a reasonable range without requiring multiple medications at all. This is what individualized medicine actually means: treating the human being, not only the measurement. And yet modern healthcare systems often struggle to practice medicine this way because time itself has become compressed. Many physicians operate under short appointment schedules with overwhelming patient volume. Guidelines become simplified checklists. Numbers become targets. Nuance disappears, but aging does not follow simplified checklists. Aging is biological complexity. And perhaps nowhere is that complexity more obvious than in what happens when an elderly person stands up suddenly. This is where one of the most important home tests for older adults becomes critically valuable: the orthostatic blood pressure test. Most patients have never heard of it. Many clinics do not perform it routinely. Yet it may identify dangerous blood pressure instability before catastrophe occurs. The process itself is surprisingly simple. Lie flat quietly for 5 full minutes, measure blood pressure while still lying down, then stand up immediately and measure again right away. Now compare the numbers. If systolic pressure drops more than 20 points, or diastolic pressure falls more than 10 points, this strongly suggests orthostatic hypotension, and for elderly adults taking blood pressure medication, that finding deserves serious medical attention. Consider a real example: lying down, 125/78 standing, 98/64 on the surface. The seated clinic reading might look excellent, but physiologically, the standing reading reveals the brain may be underperfused during large portions of daily life. Every time the person stands, circulation briefly fails to keep up. The consequences can include dizziness, mental fog, blurred vision, fatigue, weakness, instability, and falls. And what makes this especially dangerous is that many older adults normalize these symptoms completely. I'm just getting older. I stood up too quickly. My balance isn't what it used to be. But these symptoms may actually be warning signs that treatment has become too aggressive for the body's current physiology. This is why experts increasingly encourage older adults to maintain home blood pressure logs instead of relying solely on isolated clinic measurements. Blood pressure fluctuates naturally throughout the day, and single office readings may completely miss dangerous patterns happening at home. Morning measurements, evening measurements, standing measurements, symptom tracking. Together, these create a far more accurate picture of what the body is truly experiencing. And perhaps the most important point in this entire discussion is this: older adults should never feel afraid to discuss symptoms openly with their physician. Dizziness is not trivial. Brain fog is not automatically normal. Aging weakness after standing matters. Falls matter enormously, because after 75, blood pressure management stops being an abstract cardiovascular goal and becomes something much more immediate: a quality of life issue, an independence issue, a survival issue. One of the most uncomfortable truths in modern medicine is that clinical guidelines often move far more slowly than biological reality. For decades, doctors were trained under one dominant principle: lower blood pressure prevents cardiovascular disease. That principle became deeply embedded into medical culture because, for middle-aged populations, the evidence genuinely supported it. Lower pressure reduced strokes, reduced heart attacks, reduced kidney damage. So the same targets gradually spread across broader populations almost automatically, including elderly adults whose physiology functions very differently. But over the last decade, researchers focusing specifically on older patient populations began uncovering something medicine had largely underestimated. Aging changes circulation fundamentally, and the older the patient becomes, the more dangerous oversimplified treatment targets can become. One reason this shift took so long to recognize is because many landmark hypertension trials historically enrolled predominantly middle-aged adults rather than frail elderly patients with multiple chronic conditions. The conclusions were then generalized broadly across age groups, but an 80-year-old body is not simply an older version of a 50-year-old body. It operates under different mechanical rules. Arteries stiffen, baroreceptor response slows, medication clearance weakens, balance deteriorates, muscle mass declines, brain circulation becomes more vulnerable to sudden drops in pressure. All these systems interact simultaneously. This is why elderly medicine increasingly emphasizes functional outcomes rather than numbers alone. Can the patient stand safely? Can they think clearly? Can they walk independently? Can they avoid falls? Can they maintain kidney function? Those outcomes often matter more than forcing a blood pressure reading into an idealized textbook category. And perhaps the greatest danger comes from how deceptively invisible low blood pressure symptoms can appear. At first, an elderly patient may not collapse dramatically. Instead, They begin moving more cautiously, they stop walking long distances, they feel mentally slower, they become fatigued more easily, they avoid stairs, they hesitate before standing. Family members often interpret this as normal aging progression, but sometimes it is not aging itself. Sometimes the body is being underperfused repeatedly throughout the day, the brain receiving slightly less blood, the kidneys filtering less efficiently, muscles functioning with reduced circulation, tiny deficits accumulating quietly until a major fall or medical crisis finally exposes the problem dramatically. This is why home monitoring becomes so important after 70. Blood pressure measured only during calm seated clinic visits may completely miss dangerous fluctuations happening during ordinary life. Keeping a 2-week blood pressure log with morning, evening, and occasional standing measurements can reveal patterns invisible during brief office visits, and patients should not hesitate to ask direct questions. What target range is safest for someone my age? Could my dizziness relate to medication? Should we perform orthostatic testing? Are my symptoms signs of overtreatment? These are medically legitimate questions, not acts of challenging authority, because ultimately, elderly blood pressure treatment must become individualized medicine rather than rigid numerical obedience. There is also an important psychological factor involved. Many older adults feel reassured when numbers become lower because lower has been culturally associated with healthier for decades. Doctors feel reassured too because guideline targets appear satisfied, but physiology does not care about emotional comfort. The body only cares whether organs receive adequate blood flow, and after 75, the margin between treatment and overtreatment becomes narrower than many people realize. This is why many geriatric specialists increasingly advocate balance instead of aggression. Protect the brain, protect the kidneys, prevent strokes, but also preserve standing stability, independence, mobility, and cognition, because for elderly adults, surviving longer means little if treatment itself destroys quality of life in the process. And perhaps the most important lesson hidden inside all this evidence is that aging bodies require individualized wisdom, not automatic protocols copied from younger populations. The numbers alone never tell the entire story. After the age of 75, blood pressure management stops being a simple numbers game and becomes something far more personal. The real question is no longer, can we make the blood pressure lower? The real question becomes, can we keep this person alive, stable, thinking clearly, walking safely, and independent for as long as possible? Because once severe falls begin, the consequences can be devastating. A hip fracture in an elderly patient is not a minor orthopedic problem. It often marks the beginning of prolonged immobility, muscle loss, hospitalization, infection risk, cognitive decline, and loss of independence. Many older adults never fully regain their previous mobility after a major fall, and what makes this especially tragic is that some of these falls may begin not with weakness, but with blood pressure being pushed too low for an aging body to tolerate safely. This is why orthostatic hypotension deserves far more public attention than it currently receives. The warning signs are often subtle: vision dimming after standing, momentary dizziness, feeling unstable when rising from a chair, mental fog, fatigue, needing to grab furniture while walking initially after standing up. These are not always harmless signs of old age. Sometimes they are circulatory distress signals from a body struggling to maintain adequate brain perfusion. And perhaps the most empowering message in this entire discussion is that elderly patients can actively participate in identifying these problems early. Home monitoring changes everything. A reliable blood pressure cuff costing around $30 can provide far more meaningful information than many people realize when used correctly and consistently. Morning readings, evening readings, standing readings, symptom logs, together, they create a much more complete physiological picture than one isolated office measurement ever could. This is especially important because clinic readings themselves can be misleading. Anxiety, timing, posture, hydration status, recent meals, medications, and stress all influence blood pressure temporarily. The body does not live inside a doctor's office, it lives through thousands of daily transitions between sitting, standing, walking, sleeping, eating, and moving. That is where dangerous pressure instability often reveals itself, and perhaps one of the most important changes elderly patients can make is shifting from passive acceptance to informed discussion. Bring written measurements. Bring orthostatic results. Describe symptoms clearly. Ask specific questions. What target range is safest for my age and health? Could medication adjustments improve my balance? Are we treating my overall health or only my numbers? These conversations matter enormously because blood pressure treatment after 75 should never be automatic. It should be individualized. A frail 85-year-old with balance problems and kidney disease may require very different management from an active 76-year-old who remains physically strong and independent. Same age category. Completely different physiological realities. This is why modern geriatric medicine increasingly emphasizes precision rather than rigidity. Protect circulation without creating dangerous hypotension. Reduce stroke risk without destroying mobility. Support longevity without sacrificing quality of life. And perhaps the strongest message hidden inside the evidence is this: low blood pressure is not automatically healthy in elderly adults. Context matters, symptoms matter, standing blood pressure matters, frailty matters, medication tolerance matters. The body changes with age, and medicine must adapt with it, because ultimately, the goal is not helping a chart look perfect. The goal is helping a human being remain alive, alert, mobile, independent, and safe. And once people understand that distinction, blood pressure stops being treated like a scoreboard and starts being understood for what it really is: a dynamic survival system that must be managed according to the realities of aging physiology, not simply according to numbers printed inside outdated guidelines.